The primary immunization, infant immunization in UIP is given at the age of 6, 10, and 14 weeks for solid scientific reasons, which is backed by the WHO. This is also followed by the same schedule is followed in private practice in India. And I think it's time to update the infant immunization, at least have a second look at the schedule for solid scientific reasons. We will be doing a brainstorming on this particular topic. I'm Dr. A. Padmanabhan, a senior consultant in pediatrics. The disease epidemiology of a vaccine preventable diseases in a country often determines a particular vaccination schedule. Since the majority of childhood infectious diseases cause morbidity and mortality at an early age in developing countries, there is a need to protect children at the earliest opportunity through immunization. This is the reason why early and accelerated schedules are practiced in developing countries, despite the known limitation of younger age immunization, which are interference with maternal antibodies and a not so well developed immunological system for the infant. And this is advised even by the WHO. Immunization schedules commencing at 2 months and having 2 months spacing between the doses are considered technically appropriate and are followed in developed countries. However, for operational reasons, an early completion of immunization at 6, 10, and 14 weeks is chosen in developing countries like India. With the availability of newer vaccine and increasing maternal immunization even in developing countries, an immunologically superior schedule of 2, 4, and 6 months may have to be considered for the future. I advance two reasons why immunologically superior schedule of 2, 4, and 6 months should be considered in private practice in India. First, reason number one is the hepatitis B vaccine schedule, the issues regarding that. Now, if you look at the immunization schedule of the United States of America in 2025, you would find that the first dose is given at birth, the second dose within 4 weeks. But regarding the last dose, it is given 8 weeks after the second dose, 16 weeks after the first dose, and the minimum period at which it should be given is 6 months. It should not be given within the 6 months if it's the third dose or the final dose. Therefore, if you look at it carefully, what you have to think is the minimum age, re-emphasize age for the final dose. If you are giving 3 doses at birth, 4 weeks, and then 6 months, or if you are giving another dose at the 4th month, you should give it at 24 weeks only. The last dose should not be given before 24 weeks. And the minimum interval of dose 1 and 2 is 4 weeks, between 2 and 3 is 8 weeks, and dose 1 to 3 is 16 weeks, and the most important, the last dose is 24 weeks. Sometimes we do administer 4 doses of primary immunization also. Therefore, the CDC schedule for primary immunization is 0, 2, and 6 months. That's all they advise. They don't advise primary immunization schedule of 4 doses, and they do not advise a booster dose. So the last dose is given at 6 months. This is very important to note. Even many consultant pediatricians may not be aware why exactly we give no booster doses for hepatitis B vaccine at 1.5 years when we do so for most of the other killed vaccine like DPT. The evidence is in a study in Alaska in USA, which is an intermediate endemic area, a 3-dose vaccination schedule, the second dose after 1 month, a third dose after 6 months, with a plasma-derived hepatitis B vaccine in a cohort of 1,578 uninfected persons aged 6 months to 50 years, prevented all clinically apparent and chronic HBV infection for at least 30 years. Population-based studies in areas with a high endemicity of HBV infections have demonstrated that active post-exposure vaccination is highly effective in preventing infection when the first dose is administered soon after birth, the second at age of 1 to 2 months, and the third at 6 to 8 months. There is no long-term studies which shows efficacy of HPV vaccine when the final dose is given as 14 weeks, as we are doing in UIP schedule as well as in our private practice in India. If you look at the current immunization schedule of the UIP, we all know that the hepatitis B is given at birth, 6 weeks, 10 weeks, and 14 weeks. 6 weeks, uh, 10 weeks, and 14 weeks. 6 months it is not given. The last dose is not given at 6 months, and the booster doses are also not given. We are quite aware of it. Now, therefore, and further, the last dose not at 24 weeks, and the interval between the first and the last dose is less than 16 weeks, and the second and the third dose are only 4 weeks. Therefore, we do not follow what is given in the immunization by the CDC guidelines. If you look at the IAP immunization schedule of 2025, it advises a 4-dose schedule at birth, 6, 10, 14 weeks, but there's no dose at 6 months, or nor is there a booster dose advice. Now, the CDC immunization schedule, though it contains only 3 doses, the Nelson's Textbook of Pediatrics, the 26th edition, also advises a 4th dose schedule, because we might have to do so when we give combination vaccine. But the doses are given at 0, 2 months, 4 months, and 6 months. The additional dose is given at 4 months, can be given at 4 months according to Nelson's Textbook of Pediatrics. Therefore, even the IAP schedule of 2025, the last dose is not given at 24 weeks as evidence mandates us to do, and the interval between the first and last dose is less than 16 weeks, and the second and third dose is only 4 weeks. Now, many pediatricians would vouch. They say, anyway, we are giving a booster at 1.5 years when we are giving hexavalent vaccine. Please remember that immunization vaccines we are giving to normal children, and to give any extra vaccine when there is no evidence for its benefit is not acceptable. WHO recommends multiple options for adding hepatitis B vaccine to the existing immunization schedule without requiring additional visits for immunization. Schedules should optimize the percentage of children completing the hepatitis B vaccine series, which can be achieved with early administration of the vaccine. The WHO recommends minimum interval between dose 1 and 2 is 4 weeks, and the minimum interval between dose 2 and 3 is again 4 weeks. Scheduled with these minimum intervals, 6, 10, and 14 weeks, has zero conversion rates similar to schedules with longer intervals. I don't know what is the evidence, from where they got this evidence. Although with lower final anti-HBs concentration. The WHO recommended interval for infant hepatitis B vaccination are shorter than those recommended in the United States. We have already seen this. Although the data are limited regarding long-term protection for schedules with shorter intervals, alternate schedules are often not feasible. This is the reason why WHO advises 6, 10, and 14 weeks. But this feasibility it is definitely feasible in private practice in India. In addition, the concerns about the long-term protection are of less practical significance in countries with high endemicity, where most HBV infections are acquired in childhood. When I went into the details, I found out that most of India is in intermediate endemicity, and Kerala is in low to intermediate endemicity. Do we need to risk long-term protection of hepatitis B infection for operational reasons in private practice? The answer to that is a definite no from myself. The second reason why I would advocate for the 2, 4, and 6 months immunization schedule is because of the blunting of childhood immunization, especially in mothers who have been given maternal Tdap. WHO has evolved exhaustive guidelines for the administration of Tdap or TD in pregnant women, which IAP endorses. In the unimmunized mother, for pregnant women who have not been previously immunized, 1 dose of Tdap or TD is advised, and another dose of TD at least 1 month apart should be given during pregnancy. The first dose should be administered at the time of the first contact, as early as possible, and the second dose of TD should be administered 1 month later and at least 2 weeks before delivery. A single dose of Tdap TD should be administered in each subsequent pregnancy. For fully immunized mothers, that is 5 childhood doses, 3 primary doses plus 2 booster doses, and 1 adolescent booster, Tdap 1 dose is necessary in every pregnancy in the schedule mentioned earlier. IAP recommends immunization of pregnant women with a single dose of Tdap during the third trimester between 27 weeks to 36 weeks of gestation, regardless of the number of years of prior TD or Tdap vaccination. Tdap has to be repeated in every pregnancy, irrespective of the status of previous immunization status with Tdap. The Indian scenario is the primary immunization with whole cell vaccine is 6, 10, and 14 weeks of age, and is followed by the boosters at 16 to 24 months and 4 to 5 years of age. This is the Indian scenario in the government sector. There is no national policy for booster immunization of pregnant women or any specific age group beyond 5 years. Limited usage of SLA-AP vaccine at 10 years and during pregnancy exists in the private sector. The WP vaccine is not offered to older children and adults, including pregnant women, due to the risk of adverse effects. Maternal antibodies may interfere with infant responses to routine immunization with Tdap-containing vaccine, raising concerns of suboptimal protection after infant vaccination. This immunological interference is called blunting. This blunting has been observed for maternal antibodies acquired after natural infection, but also for maternal antibodies induced after vaccination. The blunting of the response to infants serious, but the children did develop adequate antibodies by the end of complete series. To give the booster, probably the evidence reviewed relates only to the use of AP containing vaccine in pregnancy, and the immunogenicity data are confined to infants vaccinated with AP containing vaccine. This is the WHO position paper on 2015. Conclusions on maternal immunization cannot be extrapolated to infants receiving WP vaccine in the absence of additional immunogenicity and safety data. The value of this strategy will need to be further assessed in women who have been primed with the AP vaccine in childhood and also evaluated in low and middle income countries where early accelerated schedule using WP combinations are in place. Multiple studies from multiple authors actually gives a muddled scenario. I will give you a sense of it by reading out some of the studies. Studies evaluating the attenuation of DTAP responses by infection-derived maternal antibodies have had heterogeneous findings. This is a New England Journal article. Overall, however, there was a greater attenuation of immunogenicity in infants who received DTP vaccine containing whole cell vaccine than in those who received DTP vaccine containing acellular vaccine. There are emerging data on the effect of vaccine-induced maternal pertussis antibodies on infant DTAP responses, whereas no studies have assessed such responses in those receiving DTWP vaccine. Indian studies show that children of mothers who have taken DTWP primary vaccination in childhood do not have adequate protection. I have presented data as such, and therefore sometimes it can be quite confusing. Therefore, I have to be truthful when I present the data. Now, to bring clarity onto this, this article looks good. This is an article published in 2019 in the Lancet Infectious Journal. It shows maternal pertussis vaccination and its effects on immune response of infants aged up to 12 months in Netherlands. Together, our data suggests that timely Tdap vaccination around 30 to 32 weeks of pregnancy leads to term babies having high pertussis antibody concentration until at least the age of 3 months, which might allow for a delay in primary vaccination up to age of 3 months. We don't want to push it to 3 months. We'd be very happy with 2 months. Our data also support the introduction of 2+1 schedule starting at the age of 3 months, given the antibody concentration is similar between infants on this reduced schedule with maternal Tdap vaccination and historical data of 3+1 schedule starting at the age of 2 months without maternal immunization. However, the value of this delayed and reduced schedule will depend on the coverage of the Tdap vaccination in pregnancy, and the effectiveness of this schedule should be closely monitored. Mind you, we are advising in private practice to mothers who have had a proper Tdap vaccination in pregnancy, and therefore the coverage in the community does not matter. And we are pushing it only up to 2 months. When you consider epidemiological evidence for blunting of antibody response to infant immunization, currently there is no epidemiological evidence that children whose mothers receive Tdap are at increased risk of pertussis after pediatric vaccination, although longer follow-up is required. Mind you, this is from Western countries where the vaccination schedule is 2, 4, and 6 months. There's no increase in childhood pertussis in countries with the universal maternal immunization program, and the universal maternal immunization program are present only for pertussis vaccines are present only in developed countries. In case of pertussis disease for which no agreed correlates or protection exists, close monitoring of the impact of maternal Tdap vaccination program is needed. Therefore, even in Western countries which they follow the 2, 4, and 6 months schedule, they say close monitoring is required when you give maternal Tdap vaccination. Life. So coming back to the basic question, is it time to update the infant primary immunization schedule in private practice to 2, 4, and 6 months? Is it the right time to change the immunization schedule from 6, 10 to 2, 4 months in private practice in India to enhance the long-term protection in hepatitis B and address the blunting immune response in infants, particularly of mothers who receive Tdap during pregnancy? The information provided certainly prompts reflection among the pediatricians in private practice who are unaffected by operational challenges and who remain committed to delivering the best standards of care that science provides for children, especially when their parents trust them by following a technically appropriate schedule. I would agree that it's an appropriate time to transition to a schedule of I would argue that it's an appropriate time to transition to a schedule of 2, 4, and 6 months in private practice, particularly for mothers who receive the Tdap vaccine during pregnancy and are negative for SBHIG. Thanks for listening so long. I'm Dr. A. Padmanabhan, a senior consultant in pediatrics. You can contact me regarding this matter in my email padmanabhan.a1 or in my WhatsApp me to this number mobile 9633794520. Have a good day.